The topic for today's discussion is Polycystic Ovarian Syndrome. It is a very beautiful article, explain everything very well, published in 2017. So, what is Polycystic Ovarian Syndrome? It is basically a condition that has a number of reproductive and general health implications, and it is a commonest endocrine condition with the prevalence of 10 to 15%. The symptoms of PCOS are, as you already have known, that it is menstrual cycle disturbance, hyperandrogenism, hirsutism, acne, and alopecia with associated fertility problem. So there is a significant heterogeneity of presentation. The other thing is ovarian hyperandrogenism is thought to have genetic origin with amplification in some by hyperinsulinemia secondary to insulin resistance, which in turn promoted by obesity. So in obese patient there is increased insulin resistance, and that will lead to decreased serum hormone binding globulin, and that will lead to increased androgens, and that will affect the ovaries. So the presenting complaint in adolescents will be acne, and in older women the presenting symptom will be infertility. PCOS may be associated with increased risk of type 2 diabetes, metabolic syndrome, and endometrial cancer. Because they have very prolonged cycles and prolonged amenorrhea, that lead to increased risk of endometrial. There will be no endometrial shedding, so that's why that increased risk of endometrial hyperplasia, and that lead to endometrial cancer. So different options available are, that is, the first one is lifestyle modification, and the PCOS lifestyle modification, and those who want fertility. For menstrual regularities, we will do her hormonal treatment, and those who want fertility, so different fertility options are available, ovulation induction or gonadotropin therapies. So PCOS appear to be underdiagnosed as a result of patient should not be managed appropriately. So in a PCOS, first of all, when your patient encounters such type of patient, then you will involve those especially who want fertility, and especially those who don't want fertility, but you have to involve the multidisciplinary team that include physician, gynecologist, reproductive specialist, endocrinologist, diabetologist, dermatologist, dietitian, and psychologist. So when you have a station OSCE station, then you have mention this point that you will involve the multidisciplinary team that include physician, gynecologist, reproductive specialist, endocrinologist, diabetologist, dermatologist, dietitian, and psychologist. So because dermatologists that will cover the hyperandrogenism, and those in gynecologists that will cover her fertility, and for example physician and because they are psychologically very depressed, so we will also involve psychologist, and physician will cover if the patient develop diabetes or any other comorbid condition. So definition and diagnosis. So we have the definition regarding to, in 2003, the ASHRAE and American Society Reproductive Medicine has a consensus meeting in Rotterdam and proposed that a diagnosis of PCOS should be made if 2 out of 3 criteria are met. So we have to follow the Rotterdam criteria, in which we have 3 points, in which there are 3 points. So you have, if there is 2 out of 3 criteria, then we will diagnose that it is polycystic ovarian syndrome. If the patient have only one symptom, then you will not say that it is a PCOS. You must have at least 2 criteria out of 3. The first one is clinical or biochemical feature of hyperandrogenism, oligo-ovulation or anovulation. Clinically means the patient have visible hairs on the face and on the especially the chin area, arms, and the other thing, biochemical feature is then we have to do her serum testosterone level. Usually it is normally less than 5, but we have to exclude other causes of hyperandrogenism. Oligo-ovulation or anovulation and polycystic on ultrasound, once appropriate investigation have been performed, or exclude other causes of menstrual disturbance and androgen excess. So, the diagnosis required the exclusion of specific underlying disease of the adrenal or pituitary gland, for example, hyperprolactinemia, acromegaly, congenital hyperplasia, Cushing syndrome, androgen secreting tumor of the ovaries or adrenal gland. So, when you have to when there is hyperandrogenism, then these are the DDs for hyperandrogenism especially. So in hyperandrogenism, one of the causes is PCOS, and you have to exclude other causes as well. You have also asked about the history regarding any breast discharge from the breast, milky discharge from the breast, regarding the tumor of the ovary and adrenal gland symptoms, Cushing syndrome symptoms, and hyperplasia, congenital hyperplasia symptoms. So you have to ask all the symptoms of these specific differentials. So there is a considerable heterogeneity of symptoms and sign among with PCOS. For individual, these may changes over time. So they have beautifully explained the symptoms and possible late sequelae. If you have not, if you only read this specifically these boxes, so this is a summary of all what I have read before. So symptoms, they have explained that hypermenstrual distress, infertility, obesity, and the possible late sequelae are type 2 diabetes mellitus, dyslipidemia, hypertension, cardiovascular disease, endometrial carcinoma. So for revision purpose, and especially in talk, you only read these tables, then it will cover your whole topic. But you have to read certain, at least at first time when you read the talk article, you have to read thoroughly and full. But for revision, you need only these tables, because they very beautifully explain everything in these small tables. So then after that, polycystic can exist without clinical sign and symptoms, may be precipitated by various factors, most predominantly increase in body weight. So, despite continues regarding the reliability and reproducibility of various tests, whether ultrasound or raise serum LH, testosterone and estradiol in associated with LH or normal level of FSH, and abnormalities of estrogen secretion are variable finding, and sometimes the endocrine profile may be normal. It is thought that ovarian hyperandrogenism is driven by LH in slim women. Persistent secretion in slim women, there is persistent secretion of LH, so that will lead to hyperandrogenism, and in overweight obese women by insulin. So you have to differentiate there. The why slim women have also PCOS, because there is hypersecretion of LH that lead to ovarian hyperandrogenism, and in overweight there is basically insulin resistance. So you have to differentiate between these two. For example, in exam, when you have to ask about, when examiner ask about why in slim there is PCOS, so you have to tell about that there is persistent secretion of LH. So ultrasound, we already explained that it is one of the criteria for Rotterdam criteria. So in ultrasound, the findings would be ovary with 12 or more follicles measuring 2 to 9 mm in diameter or increase in volume more than 10 centimeter. Okay, so you must have to memorize this, that ultrasound findings will be 12 or more follicles, 2 to 9 mm in diameter, or increase ovarian volume more than 10 centimeter. So it will look like pearl string beads arranged at the periphery of the ovaries. So the biochemical marker of AMH may be even more precise than ultrasound, with a threshold of serum concentration more than 35 picomole per liter. But usually we will not do, but it is more precise. In one of the MRCG book, will be an SPA regarding that beside ultrasound, what other investigation we can do for more precise than ultrasound, which test, so that will be AMH, anti-Mullerian hormone. It's just for SBA, but to routine purpose we will not do anti-Mullerian hormone, we will do ultrasound. Serum endocrinology in PCOS increase normal androgens, testosterone and estradiol, normal or normal LH elevated in 40%, usually slim women, normal FSH. Increase or normal fasting insulin not routinely measured, insulin resistance assessed by glucose tolerance test. Decrease or normal sex hormone binding globulin result in elevated free androgen index calculated by total testosterone multiplied by 100 divided by serum hormone binding globulin. So it will also be one of the SBA that how to calculate the level of free androgen index. So we will calculate by total test. We will take the total testosterone of the patient and divided by serum hormone binding globulin and multiply by 100. Increase or normal estradiol level and increase AMH. As you can see there beautifully, the pictures, the pearl beads string like peripherally arrange the follicles. Epidemiology, that I've already discussed, that prevalence in general population not been definitely determined. So several studies that say that there may be family history of PCOS, then it will be an cause, or other that it is a basically genetic predisposition. PCOS and metabolic abnormalities. So in PCOS and metabolic, the presence of insulin resistance, subtle obesity, and dyslipidemia appear to place women with PCOS at high risk of developing diabetes and cardiovascular disease. So PCOS have a certain effect on different systems, like they will lead to dyslipidemia and later on high risk of developing diabetes and cardiovascular disease. So a possible hypothesis for survival of PCOS in the population is that of the 30-50 phenotype genotype, wherein times of feminine individual who have tendency to obese preserve the population by maintaining fertility, with those normal body weight fall below the threshold body weight for fertility. So women who are obese, or also many women or many slim women with PCOS, will have insulin resistance and elevated serum concentration of the insulin. So insulin resistance is defined as a reduced glucose response to given amount of insulin and may occur secondary to resistance to the insulin receptor. Decreased hepatic clearance of insulin, or that will lead to increased pancreatic sensitivity. So both obese and non-obese women with PCRs are more insulin resistant than age and weight mate with normal ovaries. So there will be no any clear-cut cause of the PCOS, but in general theory that there is increased insulin resistance, and that will lead to decrease the hormone binding globulin capacity, and that will lead to increased androgens. Women with PCOS or oligomenoric are more likely to be insulin resistant than those with regular cycle, irrespective of the BMI. So it will have no impact. Then we say that only in obese women are prone to PCOS. Slim women can also have PCOS. Fasting insulin level are not measured in routine practice. So instead, we suggest a 75 gram oral glucose tolerance to be performed in a woman with a BMI of more than 30 kg per meter square. It has been suggested that South Asian women should have assessment of glucose tolerance test if their BMI is greater than 25 kg because of their high risk of insulin resistance and lower BMI. So this will be an SBA, that specifically in South Asian we will take a BMI of more than 25 for oral glucose tolerance test, and in general population we will take more than 30 kg per meter square. A measurement of HbA1c may also be useful. So in PCOS patient, we will also evaluate the patient annually for diabetes, because they are more prone to diabetes. So they have discussed that how serum hormone binding globulin, if increased level of androgens, they said that the insulin resistance may occur irrespective of the BMI. The commonest association of PCOS and obesity has a synergistic deleterious impact on glucose homeostasis and can worsen both hyperandrogenism and anovulation. Increased insulin decrease synthesis of hormone binding globulin by the liver, thereby decrease the serum free testosterone concentration and consequent peripheral androgen action. So that's why it lead to increased androgen secretion. So exercise has a significant effect on reducing visceral fat and reducing cardiovascular risk. Indeed, a 10% reduction of body weight may equate with a 30% reduction in visceral fat. So if you advise the lifestyle modification, when you are telling the patient that you have to reduce the weight, then the ideal weight that you will, if if the patient have weight of 90 kg, then you have to tell that you must have to reduce almost 10% of our original body weight. Definition of glucose tolerance after 75 oral glucose tolerance test. So when we say that it will be diabetes mellitus when fasting should be more than, in how we do 75 oral glucose tolerance test, we will tell the patient that at least she have fasting for at least fasting for whole night. Then in morning, first you will do fasting blood sugar, then you will give 75 gram of oral glucose, then you will check the 2 hour of glucose level after you have given the 75 gram oral glucose. So in diabetes mellitus, fasting should be equal to more than 7, and in 2 hours should be more than 11. Impaired, we call it less than 7, and 2 hours should be 7.8 to less than 11. And impaired fasting glycemia is called as more than 6.1 to less than 7, and 2 hours should be less than 7.8. Health consequences, as we have already told, that have a certain effect on lead to dyslipidemia, as that lead to hypertension, cardiovascular disease. So they have health consequences. Effect on quality of life. Obviously, they have a very effect because they are mostly when these patients encounter, young are also be affected because they have excessive acne and hirsutism, and every woman is fond from these type of because the females are very concerned about her beauty. And if usually young girls develop PCOS, so the main problem with that excessive acne, hirsutism, so because that will have a greater effect on quality of life, it have a greater psychological effects, and those specifically those who want fertility and a reproductive age, and so they have issues in fertility, so they will have a greater effect on life, and psychologically they are very depressive. So you have to, that's why we involve a psychologist for proper counseling. PCOS in adolescence. There is no agreement concerning how to diagnose PCOS in adolescence. In fact, during the transition of girls into adulthood, several features may be in evolution, may only be transitory findings. It has therefore suggested that diagnosis of PCOS should not be made until 2 years after menarche. It has been proposed that all elements of rotundum consequences are required for diagnosis PCOS during adolescence, not just 2 out of 3. So they said that in adolescence we will not take the 2 out of 3 criteria. In adolescence, we specifically for those that are above 20, those in a reproductive age. So specifically in those that adolescents, we will not just 2 out of 3 criteria, we will take the whole, there must be all the 3 of the criteria will be fulfilled in adolescence. Acne is common during the adolescence years, and in most subjects is a transitory phenomena. Hirsutism may be a better marker of hyperandrogenism, and some authors have reported that progressive hirsutism during the adolescence years may be an important sign of PCOS. So it is important to exclude non-classical late-onset congenital hyperplasia. If adolescents present with excessive hirsutism, so you must have to exclude, because they are in one differential in mind, there must be congenital hyperplasia late onset. Usually there are 2 types of that is early onset after birth and late onset usually in adolescence age. Menstrual irregularities are common in adolescence with up to 65% of n ovulatory cycles. There is a natural progression toward more ovulatory cycle with increasing age. When the PCOS cannot be confirmed, care follow-up will be required. So what are the management of hyperandrogenism? Okay, so hyperandrogenism, the testosterone is affected by serum concentration of serum hormone binding globulin. High level of insulin lower the production of serum hormone binding globulin and thus increase the free fraction of androgens. So elevated androgen concentration stimulate peripheral androgen receptor, resulting in increased 5-alpha reductase activity, directly increasing the conversion of testosterone to the more potent dihydrotestosterone. So, women with PCOS do not become virilized, that is, they do not develop deepening of voice, increased muscle mass, breast atrophy, or clitoromegaly. A total testosterone of greater than 5 nanomole, depending upon the assay, a rapid onset of hyperandrogenism require further investigation. So, in PCOS, if there is as I've all told you about that, if there is any hyperandrogenism, so you have to exclude other causes as well. So you will advise the patient testosterone level. If less than 5 nanomole per liter, then you don't have to worry about it could be due to PCOS. But if it more than 4 nanomillimole per liter, then you have to investigate further for other causes of what we call other causes of hyperandrogenism. So hirsutism is characterized by terminal hair growth in a male like pattern distribution, chin, upper lip, chest, upper lower back, a standardized scoring system such as modified Ferriman and Galway score may be used to evaluate the degree of hirsutism before and during treatment. So this is a score you have to assess. Then you have to prescribe treatment like cosmetic techniques like oral topical treatments and lasers, shaving, these type of. During therapy, make 6 to 9 months or longer before any improvement of hirsutism is perceived. So physical treatment include electrolysis, waxing, bleaching may be helpful while waiting for medical treatment to work. So certain type of medication like those having cyprotein acetate, so that will also reduce acne and hirsutism, and the combined oral contraceptive like YAS, they have a greater if when you start in PCOS. So if there will be no other cause of hyperandrogenism, so in PCOS it will work, the hirsutism will be improved. Regrowth will be common, as you know. So hair growth occur in 3 cycles, so 6 to 9 of regular treatment are typical. The other thing, the topical use of eflornithine may be effective. Eflornithine, what is the role? It is usually as a topically. It inhibits the enzyme ornithine decarboxylase in hair follicles and may be useful therapy for those who wish to avoid hormonal treatment. So when you will encounter this such type of patient, you can also prescribe her the oral. These are available in market. So they have a certain effects. The better option in the hirsutism is today, like laser therapies are better, but you have to keep in mind that these topical treatments are also available. Medical regimes should stop further progression of hirsutism and decrease the rate of hair growth. So the first line traditional therapies are DINE, as I've already discussed, cyprotein acetate, which contain ethinyl estradiol 35 in combination of cyprotein acetate. So when you there will be an OSCE station, so they will also the examiner will also ask about the preparation, and DINE contain how much ethinyl estradiol and cyprotein. So you have to memorize also these. The high doses of cyprotein acetate does not appear to confer additional benefit. The effect on acne and seborrhea is usually evident with a couple of months, and sometimes additional topical antibiotic and anti-inflammatory preparation may also be helpful. So other form of that is spironolactone is a weak diuretic with anti-androgenic properties. So it is used in whom the combined OCP is contraindicated at daily dose of 25 to 100. So you can also prescribe spironolactone. It can also affect in hyperandrogenism. For example, if patients specifically present with that I have excessive hair, so if you are considering her treatment option and there will be contraindication for COCPs, then you can also consider spironolactone. Drospirenone containing spironolactones, Yasmin. If there is no contraindication for COCPs, then you can also prescribe Yasmin, because it contains both the drospirenone, progesterone, and along with spironolactone. So both will have a greater effect. In reality, all oral preparation should be beneficial both for control of menstrual cycle and suppress hyperandrogenism. So it will regulate her cycle and also will suppress her hyperandrogenism. Other anti-androgenics such as finasteride and flutamide has been tried but not widely used in the UK. The management over there will also alopecia is difficult, may be stabilized by androgen. Iron deficiency may have an impact on cardio, so ferritin level should be assessed. So menstrual problems, because you have to treat her menstrual problems, because in this type of patient, if prolonged amenorrhea or oligomenorrhea or irregular cycles, then you have to regulate it, because in case of this prolonged amenorrhea, that lead to endometrial hyperplasia. So they have explained this. Okay, so in this this paragraph is important and related to management in menstrual cycle, that it is therefore important that women with PCOS shed their endometrium at least every 3 months. Okay, for those women with oligomenorrhea who do not wish to use cyclical hormonal therapy, we recommend an ultrasound scan to measure endometrial thickness and morphology every 6 to 12 months. So it will be an SPA, and very important point that you have to shed the endometrium at least every 3 monthly in women with PCOS, because they will engage of hyperplasia and lead to endometrial CA. And if the patient decline, then you have to do ultrasound every 6 to 12 months. And if the endometrial thickness greater than 10 mm in amenorrheic women, warrant artificially induced bleed, which should be followed by repeat ultrasound and endometrial biopsy if the endometrium has not been shed. So another option containing a progesterone, Mirena, also available. तो अगर फॉर एग्जांपल पेशेंट का एंडोमेट्रियल थिकनेस ज़्यादा है, शेड नहीं हो रहा, तो आप उसको मायरीना भी ऑप्ट दे सकते हैं. अच्छा, very important regarding to anovulatory infertility, important regarding the both in SPA and OSCE station must आता है इस पे. ठीक है, तो in point of view of OSCE, this type of management of anovulatory infertility important. So PCO account for 80 to 90% of women with anovulatory infertility. So in this case, the principal management of anovulatory infertility are first to optimize health before conventional therapy. So for example, lose weight in those who are overweight, and then to induce regular unifollicular ovulation, folic acid should be taken at a daily dose of 400 microgram on those who are obese, 5 mg. Okay, so one of the folic acid dose, we in 5 mg, we can also give a neural tube defect, and in those having sickle cell disease, in thalassemia, so it is in obese we can also give 5 mg, otherwise we will give 400 microgram. Semen analysis should be performed before ovulation. So when the patient presents with infertility and the patient is having PCO, so you also have to take a detailed history of infertility from both in respect to female, and also the male history is also important, as the primary and most common cause of primary infertility is male infertility. So before proceeding toward the ovulation induction, you must confirm through investigation that semen analysis will be normal. If the semen analysis will be normal, then we will consider that there will be in PCOS, there will be anovulation that will lead to infertility. So then we have to start the ovulation induction. Obesity and lifestyle, obviously you have to advise a lifestyle modification, include reduce overweight, 5 to 10% of the body weight from normal body weight, you have to reduce it. So British Fertility Society guidance suggests that treatment should be deferred until BMI is less than 35 kg per meter square, and although in those with more time, for example less than 37 years, normal ovarian reserve, a weight reduction to BMI of less than 30 kg per meter square is preferable. So you have to memorize this point, that those patients who have BMI of the treatment should be deferred until BMI. So in those patients, those having BMI of more than 35, so you will not give a treatment option of ovulation induction. First, you will reduce her weight, reduce her BMI. If it is less than 35, then you will start treatment. And other condition is that in those having age of less than 37 years with normal ovarian reserve, a weight reduction to a BMI of less than 30 is preferable. Okay, so these 2 points are very important. You have to memorize that in a BMI of less than 35 more than 35 kg, you will not give deferred treatment until the BMI is less than 35. And in those the age having less than 37 or normal ovarian reserve, so the cutoff for these type of patient is 30. So in this case, you will tell the patient that you will start her treatment once the BMI is less than 30, and 5 to 10% should be reduced. So the diet basically lifestyle, it is sensible to reduce glycemic load by lowering sugar content in favor of more complex carbohydrates and to avoid fatty food. Meal replacement therapy, low caloric diet, and 30 minutes per day of brisk exercise encouraged to maintain health, but to lose weight or sustain weight loss, 60 to 90 per day is advised. So as you can see that this talk explain everything very beautifully. That what you have to tell the patient, it is very important. If the station come as a counseling, so what you have to tell the patient, that how much you have to reduce the weight, what type of food you have to eat. So they have told you that the glycemic load, that will low sugar content, and you'll also tell about that the 30-minute per day of brisk exercise or a sustained weight loss 60 to 90 minutes per day is advised. No medication have shown to assist with loss. So usually medication for weight loss have no role. Bariatric surgery we should be only consider if those having BMI of more than 40 kg per meter square should be referred for consideration of bariatric surgery. So it is also an SBA. In home patient, you will offer bariatric surgery those having BMI of greater than 40. And if there are comorbidities such as diabetes, then the BMI cutoff for surgery may be lower than 35 kg per meter square. Okay, so this paragraph is also important. Ovulation induction therapies, there are different therapies like for ovulation induction, that are clomiphene citrate, parenteral gonadotropin therapy, and laparoscopic ovarian surgery. Clomiphene citrate, it is a first line therapy and it is usually commenced on day 2 to 5 cycle and is given for 5 days. And if the patient have oligoamenorrhea, it is necessary to exclude pregnancy and then induce withdrawal bleed with a short course of progesterone such as medroxyprogesterone 20 mg per day for 5 to 10 days. So if the patient is oligoamenorrhea, amenorrhea, then we have for withdrawal bleed we give medroxyprogesterone 20 mg per day for 5 to 10 days. When the bleeding starts, then we will start her on ovulation induction day 2 to 5 of the cycle. So the starting dose is 50 mg per day. And if the patient is not menstruated by day 35 and she is not pregnant, a progesterone-induced withdrawal bleed should be initiated. The dose of clomiphene may be increased to 100 mg if there is no response. Dose of 150 mg per day or more do not appear to be of benefit. If there is exuberant response to 50 mg per day in some women with PCOS, the dose can be decreased to 25 mg per day. And if the patient is ovulating, conception is expected to occur at a determined by factors such as patient age. Clomiphene citrate induce ovulation approximately to 70 to 85% of the patient, and approximately 60 to 70% should be pregnant by 6 ovulatory cycle of therapy. So this is also an important paragraph, that once the patient is presented with oligoamenorrhea, then you have to withdrawal bleed, then for start clomiphene citrate from day 2 of the cycle up to 5 days. Initial dose will be 50 mg per day. You have to increase the dose up to 150 mg, not more than that. And maximum cycle for ovulation clomiphene citrate should be at least 6 cycle. You have to complete the 6 cycle of clomiphene citrate, and you have to follow with ultrasound to check the follicular size. If the follicular size if 18 up to 20 mm, then you will give HCG to for trigger to release the for ovulation for ovulate for trigger the ovary to release the what we call as for ovulation. So it is also important you also tell about that tell the patient that clomiphene citrate induce ovulation up to 70 to 85% and 60 to 70% should be pregnant by 6 ovulatory cycle of therapy. So when this type of station came in counseling, so you have to tell the patient that 60 to 70% chance that you will be pregnant by 6 ovulatory cycle. Hypersecretion of LH is found in 40% of the women with PCOS and reduced chance of conception and increased risk of miscarriage through an adverse effect of LH on oocyte maturation, because when the LH is hypersecreted, so it will affect ovarian maturation. So elevated concentration are more often in slim women with PCOS. Clomiphene citrate may cause an exaggeration in the hypersecretion of LH and have anti-estrogenic effect on the endometrium and cervical mucus. So the authors suggest that measuring LH on day 8 of the cycle, and if persistently elevated, move on to alternative therapy as the chance of conception is reduced and the risk of miscarriage is increased. So this is another important paragraph, that in those patients where persistent hypersecretion of LH, then you have to do her LH on day 8 of the cycle, and if it is still elevated, then you will use alternative therapies, because with this, if you will continue ovulation induction, then there will be chance of miscarriage. All women prescribed clomiphene citrate should be carefully monitored with ultrasound assessment of follicular growth. The risk of multiple pregnancy is approximately 10%. So you have to tell the patient that pregnancy rate of 60 to 70% and multiple pregnancy chance of 10%. If the pregnancy is occur after 6 to 9 normal ovulatory cycle, it is then feasible to offer the cover not occur. So you will offer the couple IVF. Patients with anovulatory infertility who are resistant to anti-androgens may be prescribed parental gonadotropin therapies or treated with laparoscopic ovarian surgery. The term clomiphene resistance, strictly speaking, referred to failure to ovulate rather than failure to conceive despite ovulation, which should be termed as clomiphene failure. So the two terminologies are that what is resistance, that failure to ovulate, and clomiphene resistant is that strictly speaking refer to failure to ovulate rather than failure to conceive despite ovulation, so which is termed as clomiphene failure. That the patient is ovulating but the clomiphene will not work, so we have to change the alternative therapy. And in these cases, clomiphene failure, as the patient is ovulating and the clomiphene will not work, then we will give her, then we'll straightforward will go to IVF. And in clomiphene resistant cases, that clomiphene will not work, so we will change the alternative therapies. So you have to your mind must be clear regarding to the clomiphene. What is clomiphene resistant and what is clomiphene failure? In clomiphene failure, we will direct jump to IVF because patient is ovulating but it will not working. So in resistant cases, we will change to other drugs. Aromatase inhibitors and the use of aromatase inhibitors, that is letrozole inhibition of aromatase enzyme, decrease the aromatization of androgens to estrogen, that in turn release the hypothalamic pituitary axis from negative feedback. So it will inhibit the negative feedback of estrogen, so there will be no hypersecretion of LH. Despite the potential advantage over clomiphene citrate, the use of letrozole was discouraged following a report at a meeting that suggests a significant increase in congenital malformation in newborn and letrozole-treated pregnancy. However, more recent studies have not supported the teratogenic effect of letrozole. So the WHO has supported the use of letrozole as a first-line therapy in countries where it is used as prescribed for this. So in our country, usually we will use as a first line, we will take letrozole, because in letrozole clomiphene there is chance of multiple pregnancy and OHSS, but with letrozole there is less likely, so you can prescribe letrozole as a first line. Gonadotropin therapy for women with anovulatory PCOS who have been treated with anti-androgen, if they fail to ovulate or if have the clomiphene citrate and letrozoles are anti-estrogens. So if treated with anti-estrogen, if they fail to ovulate and if they have a response to clomiphene citrate, that is likely to reduce their chances of conception. Persistent secretion of, we have told that the persistent secretion of LH, then we have not to give the clomiphene because risk of miscarriage. Then we will change the alternative treatment, that is gonadotropin therapy. So to prevent the risk of ovarian stimulation and multiple pregnancy, low dose should be started, that 25 to 50 units of FSH. This is only increased after 14 days if there is no response, and then only half of the start dose every 7 days. The treatment cycle using approach may be quite long, up to 28 to 35 days, and the risk of multiple follicular growth is low, and multiple pregnancy rate should be less than 5%. So it is extremely difficult to predict the response to stimulation. The polycystic is characteristic question. At least when viewed by ultrasound before exhibiting an exuberant and explosive response to stimulation, it is very challenging to stimulate the development of simple dominant follicle. So when it reaches to the proper 18 to 20 mm, then we will give a trigger of subcutaneous injection HCG 5000 units when there has been the development of at least one follicle of 17 mm in its largest diameter. So when you are starting clomiphene citrate and you have to check the follicle that it 8 mm, then you also give HCG injection of 5000. In gonadotropin, and you have also given the HCG injection. So, in order to reduce the risk of multiple pregnancy and OHSS, the exclusion criteria for HCG are the development of total of 2 or more follicle larger than 14 mm in diameter. So, in overstimulated cycle, HCG is withheld. If you found out that there will be at least 2 follicles of more than 14 mm in diameter, then you will not have to give HCG, because it will not lead to because it will lead to ovarian hyperstimulation syndrome. So you have to keep in mind that if there is at least two follicle or more than 14 mm in diameter, then you have to hold the HCG injection, and the patient is counseled about the risk and advised to refrain from sexual intercourse, because if as 2 follicles of more than 14 mm diameter, if the patient because we'll withhold the HCG, and if the patient will do a sexual activity, and whether if she is pregnant, then with as already more follicles are stimulated, so when she is pregnant, then it will further increase the risk of with pregnancy HCG already increases. So when she's pregnant, then with these type of more than 2 follicles or there are 5 follicles, then there will be chance of ovarian hyperstimulation syndrome. So that's why we will tell the patient to advise to avoid sexual intercourse. So the conception rate or cumulative conception rate is 60 to 75%, and live birth rate 55 to 60% in 6 months. We also give at least 6 cycles of gonadotropin therapy. If conception have failed to occur after 6 cycle in a woman younger than 25 years or after 12 ovulative cycle in a woman older than 25 years, it can be assumed that an ovulation is unlikely to the cause of couple, and assisted reproductive, usually IVF, is now indicated. Insulin sensitizing agent like metformin. It is locally assumed that therapy achieve fall in serum insulin concentration should improve the symptom of PCOS. The biguanide and metformin both inhibit the production of hepatic glucose, thereby decreasing the insulin secretion, enhance insulin sensitivity at the cellular level. So, many studies have been carried out to evaluate the reproductive effect of metformin in patients with PCOS. So, it is suggesting that metformin can improve fertility in women with PCOS. However, large RCT have observed limited benefit from metformin as a first-line therapy in combination with other drugs in enhancing the chance of live birth. So those are the clinicians prescribe metformin for losing the weight. So it will not be a good option. These patient or better to have everyone has his own experience. So sometime that will affect, because it will increase the insulin level and decrease insulin resistance. So if there is no hypersecretion of hyperandrogenism, so the chance of ovulation will be improved. So for that purpose, they will give the metformin. So there are different studies in different people. So when metformin is added to clomiphene citrate in women with clomiphene citrate resistance, clinical pregnancy rate is increased in both obese and non-obese, but there is no improvement in live birth rate. So in this is a special case when there is clomiphene resistance, then you add the metformin, so the clinical pregnancy rate is increased. So highlight this point, okay? In summary, metformin has a limited value in management of innovative PCOS but could be used alone to improve ovulation rate and pregnancy rate if facilities are not available for monitoring of clomiphene citrate or gonadotropin, which are more effective. So if you are not, because clomiphene or gonadotropin in this monitoring, so in that, if you are sitting in that setup, that the patient are poor to follow up, then you have to start her on metformin, so it have a slight effect on improve ovulation and pregnancy rate. Limited evidence. For a systemic review, that metformin combined with lifestyle modification with PCOS may improve body weight. For those with PCOS and impaired glucose tolerance or type 2 diabetes, metformin is a better defined. Surgical ovulation. Surgical ovulation induction ovarian drilling. In addition to laparoscopic ovarian surgery, useful therapy for innovatory infertility for innovative women with PCOS who fail to respond to clomiphene citrate and who persistently hypersecrete LH need a laparoscopic assessment of their patient, or who live too far away from the clinic to be able to attend for the intensive monitoring required of gonadotropin therapy. Only fully trained laparoscopic surgeons should do. So this will be a very last option. You will not, in our setup, usually it will not it is not a preferable option for us. So in special case, if an exam point of view, you have to remember this, that those having persistent hypersecretion of LH and those who have to attend the if you are prescribing gonadotropin therapy, it need intensive monitoring. So in that case, you will can consider laparoscopic ovarian drilling. So as you can see that how much what is the procedure, it 4 per ovary for 4 second at 40 watts, 4 second and 40 watt. The risk of addition is far less, 10 to 20%, the wedge resection 100% in some series, and the addition are usually fine and limited evidence. So initial cumulative pregnancy rate after 6 months was 35% in laparoscopic ovarian removal versus 67% in FSH arm. So pregnancy rate would be cumulative pregnancy rate in laparoscopy is 34%, which is very less. Complication of ovulation induction, obviously OHSS, so increased risk of OHSS. So obviously we will briefly discuss the OHSS in the GTG guidelines. So we will discuss in detail in that guideline. IVF in women with PCOS. So obviously it's not a first line treatment for PCOS. It is the first line in unexplained infertility. In PCOS, you must have to give the other treatment. If that fails, then we'll proceed toward the IVF. So either because there is no another option for infertility, or because they fail to conceive despite ovulation, whether spontaneously with assistance, their infertility remain unexplained. Furthermore, 25 to 30% of the women with polycystic ovaries are detected by ultrasound scan. Many will have a little in the way of symptom and many present for assisted conception treatment because of other reason, for example tubal factor or male factor. When stimulated, these women with asymptomatic polycystic ovaries have a tendency to respond sensitively at increased risk of developing OHSS. So care must be taken, and there is evidence of reduced risk if protocol using a GnRH antagonists are applied. So what are the pregnancy outcomes if the patient get pregnant and those having PCOS? So it will affect greater factors that contribute to subfertility in women with PCOS: obesity, metabolic, inflammatory, endocrine abnormalities on oocyte quality, and fetal development. So women who are obese are more likely to experience miscarriage and pregnancy complication. So a number of studies have compared pregnancy outcome with women with PCOS. So there are significantly high risk of developing gestational diabetes, PIH, preeclampsia, adverse perinatal outcome, and preterm birth. So I also tell the patient that when she's having a PCOS when she's pregnant, so we will have to follow up because these patients are more prone to gestational diabetes, PIH, and preeclampsia. So hope you will understand this talk article, and it is a very beautiful article. Most of your SPAs and OSCE stations cover from this talk. So if this talk is enough for you people, because they have explained everything very beautifully regarding to infertility, journal treatment, and for general practice, if you are practicing and when you encounter such patient, how beautifully they explain everything, lifestyle modification, and what treatment you will initially start if you are confused. Read that, and it is they are explained very beautifully. Okay, thank you so much.